conference today. Looks like we have a little bit more of an intimate group, but that's great. We have a ton of residents here in person at the university, and we'll go through this case together. So today we have a 36-year-old woman who's coming to our primary care's office, and she says that she's been experiencing episodes of sweating and tremulousness. And so I think today we're going to sort of do this in a more traditional fashion and not just jump directly to labs, et cetera, even though some very astute residents have wanted to get a kidney biopsy or an adrenal biopsy already.
That was me, sorry.
So let's see what you guys want to know more from the patient.
Characterize it a little bit better. When is it happening?
Yeah, I think that timing and characterization is great. So she says that it's sort of happening randomly throughout the day. She's a pharmacist at Walgreens and feels like it does seem worse toward the end of her shift. And then,
Any other exacerbating or relieving factors?
she thinks maybe it gets better with eating, but she's not sure, because she can't always get to food if she's working, and she'll sort of just like get through it and drink some water.
She ever done a one check?
Oh, what check?
That's the one check, the touch glucose?
Oh, yeah, she has not, no. Okay, what else?
When did this all start?
Yeah, she's a pretty avid runner also, and initially thought she was just overexerting herself and was having these episodes, so she tried to really improve her diet, see if it got better, but really it's been sort of like this for the last 3-4 months.
Has she ever passed out from these episodes?
And she denies any syncope.
Weight loss or gain changes.
Yeah, great. None that she's noticed. Her weight fluctuates within 5 pounds, but hasn't been dramatically up or down.
Think about your differential percent. What's that? What are you starting to clue in on?
I mean, I just wanted to see if maybe this is like, an endocrine type thing, like, hyperthyroidism or something, she's losing more weight, having flushing or things like that.
She using any substances?
Yeah, great, Victor. And what kind of substances specific? Alcohol?
Alcohol, opiates.
Yeah.
You can't use at work. By the end of work, you start feeling a little.
Oh, interesting, yeah. If you're not using it at work, you're feeling like you need it at the end of work. Awesome. She says she really only drinks very socially, nothing excessive, no tobacco, or nicotine products.
Any supplements?
Great, yeah. She says that she just takes a daily multivitamin that she like gets at Walgreens and nothing off the internet. And then she takes OTC.
Any history of like syncope?
No syncope.
No family cardiac history that we're aware of?
She says that her father died of an MI at 86. Mom has RA.
Okay.
Victor, why are you asking about abdominal syndrome?
It's a tumor.
If it's a
Yeah,
tumor.
secretes something.
Okay. No abdominal pain, or, yes.
Any diarrhea, things like that.
Awesome. Are you thinking along the same lines too with neuroendocrine type tumors? Yeah. Okay.
Headache,
Why asking about headaches?
going on our neuroendocrine thing.
Along the same lines.
Egos
Okay.
or,
Yeah,
yeah.
yeah. No headaches. When you ask about headaches, she says she does feel lightheaded sometimes.
Does she get these symptoms every single day, or is it a few times a week? Like, what exactly is the timing?
They seem to be worsening, so it was only happening occasionally, and she's like, maybe this is because of my running, and now it's like happening almost every day.
Has she ever fasted, and what happens when she does?
She says the most fasting that she really does is like her work day, if she ever misses lunch or doesn't eat enough for lunch, and then otherwise like sleeping is her natural fasting time. But she doesn't always notice this in the morning.
Okay, can we characterize the events a little bit more? What's the sort of order of operations here? Is she minding her own business and these symptoms start simultaneously? Does one come on before the other? How do they relieve?
Yeah, so they can happen together, individually. It's pretty random. There's nothing that comes first or second, and so she says, yeah, sometimes I get sweaty and shaky. Sometimes I get sweaty and lightheaded. Sometimes I feel just lightheaded. Yeah.
How long do it last?
Yeah, she says they're sort of lasting for an hour to a couple hours, and she just tries to like drink some juice, drink some water, try to eat if she can, and then they seem to get better.
It's a long time.
Yeah.
What does she do for work?
She's a pharmacist at Walgreens.
Okay, sorry.
Yeah.
Got it.
And when's the last time she remembers feeling completely well
Yeah.
for any of these type of symptoms existed?
She says, she's like, okay, the best I felt was 6 months ago when I ran a marathon, and I was fine.
Okay. And then sometime between now and then, these
This
things
sort
have
of
cropped up. And I guess I would follow up with, around that time period, did she change her diet, change her job, travel, or notice anything else that when she reflects upon that time as being different from the rest of her life?
None of those things. No travel, didn't change her diet, didn't start any new medication, didn't change her job. Yes, none of that stuff.
Thanks.
I don't know if this has been asked, but any becoming symptoms, fevers, chills, or recent illness?
Or recent illness, yeah. No fevers, chills, no recent illness. Why would the recent illness matter?
I'm trying to think of ways to like play with the adrenal gland, and so if this is a far shot, because I think it's primarily in the pediatric population, but like Friedreich-Waterhouse syndrome, where you can have adrenal hemorrhage, but that's zero fishing for. There's probably better reasons to ask for a back.
Or like thyroiditis
Pregnant.
type thing.
What did you say?
I said, or like thyroiditis type.
Or thyroiditis, yeah, with infection, sure, yeah, definitely.
Yeah, she's sexually active.
She's sexually active, yeah, with her husband.
Okay.
They're in a monogamous relationship to the best of her knowledge.
Any change in menses or any other concern for pregnancy?
No, so she takes her OCPs very regularly and gets her period during the placebo week, and that was just last week.
Okay.
Does she feel palpitations at all when this is happening?
Great question. Sometimes she does, yeah. Not always.
How did that help you, not help you,
So,
confuse you?
two things I was thinking of there. Swaying and tremulousness, I'm thinking, I don't know why this keeps coming to my mind, but like insulin dependent versus non-insulin dependent, like hypoglycemia. And I'm trying to think if she's getting tachycardic when she's getting these episodes of like sweating, tremulousness due to hypoglycemia, or if this could as well just be like, I mean, this is something with sympathetic activation. And so just thinking about like, is it the whole sympathetic nervous system, like what parts of it?
Yeah, and I think Eric mentioned this earlier before anybody really got to the room, where when he saw these symptoms, he immediately thought, hey, I feel like this person's sympathetic system is acting up, so let me think about what are all the things that will cause that. And I think I heard this earlier, but like a CO is in part of your guys' differential.
sorry if I missed this, does she get better when she has food, or does she ever notice it after she has food?
It's hard for her to like always get to food when this is happening, but she does think that when she can get to it, it feels somewhat better. Let's get her a glucometer. Okay, so tell us why that is gonna be your first step here when she's in clinic.
Well, I would probably just do a POC check first, just see how she's looking right now.
Okay.
I'd get like a BMP, TSH, but, I would want to send her home with glucometer. Is she feeling tremulous right now?
She isn't, she feels okay right now.
Okay. Yeah, and then I would want her to check her blood sugar when she's feeling these symptoms.
Mhm.
See if we can get a little Whipple's triad.
Love it, please. Oh my gosh, this is just amazing.
And you know what, I hate the stereotype, but is she using her own supply? Like,
Yeah, love it. Okay, great.
Yeah, as soon as you said pharmacist, I was like, there's a forward question.
So you're gonna stereotype Thomas in some way.
Is she on any meds?
One second, let's step back just 1 second. Thomas, tell the room what Whipple's triad is.
So it's like these symptoms, and then, blood sugar less than 55 during those symptoms, and then gets better with food, right? I remember it's less than 55, gets better with food,
Yeah,
or with resolution hypoglycemia.
that is bang on. Those are the three. Yep. Okay, great. So let's say that in clinic you're like, yeah, I'm gonna get a glucose right now. That's the easiest thing I can do, point of care check. And in clinic, her point of care ends up being 84. You're still, it sounds like then your next step is still to give the glucometer. You feel like you still want her to have that at home.
Yeah.
Yeah. All right, and then, okay, some more questions were being asked.
Do we have an accurate med list for her?
Yeah, she's a pharmacist. She's like, this is an accurate med list, is what I think.
what about her past medical history? Nothing?
She has had one normal vaginal delivery before, and that's it.
How long ago?
It was 4 years ago, which is 30.
Next time.
Good question.
All right, I think that you guys have a pretty good differential going right now. Tell us where you want to go next. So I'm sure she's in clinic, so we want to examine her. So tell me, what sorts of things you're looking for on this exam specifically that may help you in sort of narrowing your differential here.
And I apologize, can we flesh out the differential just a little bit more?
Absolutely,
just make sure that everybody remembers the chance to sort of contribute to, like, why hypoglycemia?
Okay, yeah.
So sorry, the question is, why hypoglycemia? Or?
No, I just saw one up there that could use a little bit of fleshing out, but there's probably a bunch of organ systems we're missing as to why this person could be having these symptoms.
I'll try to pick Victor's carcinoid syndrome.
Okay. We can sort of put it down here.
Mm-hmm.
Are we having conciliation in terms that it's like hypoglycemia? So it could just be like a tachycardia, like NOS, a little bit of an SVT that's happening. Any tachyarrhythmia to make you feel that way?
Yeah, I think the CD system is exactly what I was thinking of. We don't want to send this person home with a glucometer and say, let us know how this is going in 3 weeks if they're having near fatal arrhythmias.
Yeah.
So.
Yeah.
A little bit lower, and like last thing you'd probably like rule out, but like a psych, like anxiety disorder.
Sure, yeah, absolutely. Heard that earlier too.
To anxiety, I would think about eating disorder. Again, that's gonna be lower, but we don't know what she looks like. I just always, I think we think about it not often enough.
And even if we know what she looks like, it would be so non-specific from the outside.
Yeah.
Does that say substance use already?
Yeah, I'll put that in here. Or withdrawal, yeah.
Paroxysms of hypertension secondary to pheochromocytoma. Perhaps, I don't know.
Yep, we put you up there, yeah. Yeah, and like under our hypoglycemia broadness.
Yeah.
Absolutely.
POTS. Ehlers-Danlos.
Yeah, sometimes I think we do see patients,
Cell dysfunction.
yep, young women
Yeah.
that have this conglomerate of,
But POTS
syndromes.
POTS is a real thing.
What is POTS? I mean, I know it, but what is?
Metastatic tachycardia syndrome, but.
I bet it's something most people have not seen, because it's rare enough and hard enough to characterize, but most people probably have not had a
It's
POTS
really,
patient.
yeah. It's like, the hard thing with POTS is it's a very trendy diagnosis that like can happen and you can't prove it sometimes. So it's like a very tricky diagnosis, is what I would say, but if you can reliably, if like there's someone that has this dysautonomia that you can't like otherwise specify, that's what POTS is.
Yeah. And Thomas, you know, people in the room may not have seen it or treated it before, but can you just very briefly summarize what sorts of meds these patients usually are on and how they manage this disease?
All the ones that I know just have like really high salt diets, and then you can also do like midterm, I think. But otherwise, I don't know, besides that, do you have other?
Yeah, I think that they're told to always wear their compression stockings,
Yeah.
you know, like postural awareness. I've seen people on midodrine, I've also seen some on fludrocortisone, and then high salt diets. So those are the things that, these patients take pretty routinely. When they come into the hospital with, say, like another sickness or whatever, you should think about, hey, should I give this patient a little bit of stressful steroids to help out with their POTS so that they're not falling in the hospital. Great aside, now what should happen now?
I think this is good, and I really don't do this to torture you guys, it's just, sometimes you'll see something in clinic, and you'll be like, it might be this, and then 3 weeks later, it's not, you have to start all over, and you can keep doing that for a year, or you can see if there's a few of these that you can knock out of the first shot. So that's why I like to try to be a little bit broad at the beginning.
And I think Thomas was doing that along with the glucometer. He did mention some labs that he would get today. And then, you know, if you really are concerned about this tachycardia or something cardiac, you can also set her up with monitoring. Sounds like it's happening nearly daily for her, so something shorter term, like a Holter would be helpful. Okay, let's do, anything else that we want to put in the differential?
I'm good.
I think that's pretty good, yeah. All right, vital signs in clinic were normal for this patient. And then, so is there anything you guys are specifically looking for on exam? Needle marks, okay.
Belly, right side.
Okay.
Skin, maybe darkening like Addison's disease.
Yeah, great. Okay, and I know Amelia was wondering what she generally looks like, so she, is a normal BMI person, looks healthy, or looks well.
And hair texture.
She's Asian, so she has normal appearing black straight hair,
And like shiny.
So,
There, like, that's, I think hair is one of the things, like either laguna or really brittle hair, or thinning hair, and someone who's otherwise healthy can be a tip off for poor nutritional status for any reason.
great. No, like darkening of the skin, she hasn't noticed it. No track marks.
I think thyroid nodules.
Yeah, and then nodules, the same thing, what everyone was saying. Eric, is that what you're saying? Or Thomas?
Yeah.
Yeah,
Thyroid.
yeah, and that's something that Dr. Connors mentioned during our last conference, right, is to remember to like touch all the things that we can feel on a patient, and so thyroid is definitely one of them in hers.
I think the other thing too for that
Thyromegaly.
is like the fact that we're considering potential diagnoses with that association with thyroid and without there having to be thyroid as a primary diagnosis. So like for stuff like insulinoma, for like men and stuff like that.
Mm-hmm.
So still important even if that's not the diagnosis in the end.
Yeah.
Check like JVP, lower extremity edema, autojagged reflex.
Yeah, thinking about cards still. Mm-hmm. That's a normal. Any other systems you want to check?
Feel the belly.
Feel the belly or what?
Masses.
For masses? Yeah. Cool. Her abdominal exam is normal, no masses.
Lots of like orthostatics probably for vitals.
Awesome, yeah. Normal orthostatic.
Psychiatric exams, does she look anxious?
No, she's like behaving appropriately at the would expect, so, yeah, a well-educated pharmacist.
Does she seem like appropriately concerned about her symptoms? I know that's like a weird thing, but like sometimes you have people where it's like, they're like, oh yeah, it's like totally fine, and then it's like a little more concerning for like a tax issue or something like that.
Sometimes it's either like extreme, like, you know, it could be
Yeah.
either end of the spectrum, right? Like, people are just like absolutely freaking out, demanding all these hundreds of tests versus not really kind of nonchalantly coming to you, so. Okay. And, yeah, so she's like, you know, like I said, I was trying to figure out if I could solve this on my own. I tried to change some things, but now I'm worried that, if I keep doing like this, that I might pass out at work, and I don't want that to happen, so, I want to figure out what this is. Okay, so let me give you some of the labs that we wanted. So her BMP in the outpatient setting, ends up being fairly normal. TSH was normal. What else did you guys want to send her home with to get? Any other labs you wanted when she went home?
EKG in the office.
EKG in the office, yeah. EKG in the office was normal.
I would also probably add CBC only for the fact that we didn't ever put infectious up as a differential, but it
Sure.
certainly is a possibility. Is there
Yeah.
anything else?
Yeah, also Priscilla was saying, like, severe anemia can cause tachycardia.
Mhm.
Yeah, absolutely. Anemia can explain this, yeah. Her CBC is normal.
I like the in-office ECG as well. I mean, she'd be a great little Parkinson White candidate.
Yeah.
You know, where you can actually be out in the world for quite a while with that. Mid-30s woman's perfect.
Mhm.
If you could do a UDS too, if that was a little bit concerned.
I think that's something reasonable to do in this patient, since we, you know, it's always something that, better you just say it's not that than, you know, it is, right? So, okay, normal or negative.
Do we, do pregnancy tests?
Yeah, she's on OCPs, Thomas, and she just had her period last week.
Last week, okay.
Yeah.
Only the second part means anything at all.
Had we done one, it would be negative. Okay, and then, Victor, would you have, with the normal EKG, like, still send her with a Holter in this scenario, or waited for a stepwise approach?
I think it wouldn't be unreasonable. Yeah, if she's having daily.
Yeah.
Something that's scary. I'd probably have a monitor that somebody could call her with. In case having these events. I was very, very concerned.
Okay. So cardiac monitoring, it does, like, when she triggers it with her symptoms, does show like some tachycardia, but it's not like, nothing crazy. It's just sinus tach.
Sinus.
And I want to highlight one part of what Victor was saying is the frequency of symptoms. Because if you're going to send someone out with cardiac monitoring, just make sure you always order it at an appropriate interval to think you're going to capture it. But if someone says, like, this happens, I don't know, once every other week, make sure they have it for 2 weeks or a month. If they say it's every month, it might be really hard to capture. But with these symptoms, it's completely reasonable to think that you could event.
Yeah. And the Holter is the short-term one, right? I'm not getting that wrong.
1 to 3 days.
Yeah. And then forgetting the longer one. The
patch?
Zeo patch, yes.
And you can also do like the loop recorder, or like, that would be the perfect, like,
And then like a link or a loop recorder is like very long-term.
just between now and the end of the world, we might.
Right.
Yeah.
Let us know.
Because that's an implant, so.
Yeah.
And can you clarify, I like the idea of doing this as well before, on this first go around.
Yeah.
So is it always sinus tach when she feels these things? Is it ever not sinus tach? Is it ever nothing? Or is it pretty consistent, like every time she has symptoms, it's sinus tach?
No, like sometimes it's not, sometimes it's normal
Okay.
rate. Yeah, sometimes it's a little bit of sinus tach, like low 100, but
Okay.
it's never not those two things.
Gotcha.
Yeah.
And it's never 160s, 170s?
No, it's never that fast.
Okay.
Yeah. All right, and then sounds like glucometer, so she calls you and says, when I felt these symptoms, she calls you in like 2 days and is like, yeah, my sugars were 48 65 and 42 during symptoms.
Does she ever measure them normally?
You have one of those.
No, she had never measured them before. Yeah, just the in-office one was 84. Okay.
Okay.
So what do you guys think now? What things on the differential are jumping out to you, and what do you want to do?
Take feel off.
Take you off. Yeah, we're not seeing like consistent tachycardia with these symptoms. We have another explanation perhaps. Okay.
Sorry, when she called with those symptoms to find out, to tell us the glucose, did she tell us, like, how it got better? We asked, like, when did it go away, or what happened?
Yeah, now she like really did try to drink some juice, and then she felt better.
Okay.
Yeah. She's like, when, you know, sometimes she would just drink water, but now she's like carrying apple juice with her. Yeah. What else? What else on the differential do you guys think, up or down? Really likely, okay. We don't think thyroid is likely anymore with that TSH. Okay. How about adrenal gland problems?
Yeah, I mean, so I would keep adrenal glands on her, just because, cortisol is gonna be highest in the morning, which may explain why her symptoms may be more pronounced in the afternoon or later in the day. There is some sort of adrenal compensation there. I can't think of why her adrenal glands wouldn't be working, but it's possible. And similarly, and we can put this at the bottom of the list, but I like to substitute my fetal proposal with maybe thought about liver function, if this is like a gluconeogenesis impairment, if for some reason she has cryptogenic cirrhosis or something, that's well compensated, otherwise might be another explanation.
Liver or renal failure can both sort of cause these kinds of symptoms, right? And hypoglycemia and endocrine cells. Okay. We don't think it's carbs anymore, right? Pretty confident with that whole thermometer.
I feel better about that.
Surface uses.
Yeah.
Still wearing.
It's still up there, yeah, we still don't know, okay, we gotta sort that out for us, okay? And then how are some of these other neuroendocrine tumors? Thoughts?
What do you mean?
Like, do you think they're still on your differential? Do you think you would rule those out in any way right now?
I think carcinoma is probably less likely. I'm not hearing a lot of other systemic signaling
Type
of
symptoms,
energy agent, yeah.
I would say the surreptitious use is still going. The only time I've ever actually seen this was in somebody who came to the doctor to find out why they were feeling poorly. It was a nurse. And they just didn't think they were using that much surreptitiously. And so you would think, like, why would this person come to a doctor when they just know it can still show up?
What are they using?
Thyroxine.
Thyroxine. Okay, and then, we'll keep these tumors on here because unless I hear one way or the other.
What, sorry?
The neuroendocrine tumors, I'll keep up there, and then, MEN, I'll keep up there too. Okay. All right.
And the silence is like one of those, I have to look them up. Silence is understandable.
And then the bottom still stuff we'll just keep on until we complete our workup, because most of these, some of these are diagnoses of exclusion, right? Okay. So what now? What should we do? Be like, hey, listen, just drink some apple juice every time this happens, you're good to go?
We should probably fill out that imaging box, it's blank.
Okay, maybe once you do the service, maybe I'm gonna get some imaging, perhaps. What else could we do?
Like insulin level C-peptide, those kinds of things.
Okay, you can check insulin level C-peptides.
I can't remember, we had patients like that where we were looking into maybe an insulinoma, and I don't remember if I think you check everything when they're, like, glucose is low, yeah, when it's in like fasting, because it should be like they're typically high.
Yeah.
Yeah, what do you just have them come into the hospital for something to our best? You don't want to do it at home, 'cause,
Yeah.
you might pass out and.
Cool. You might have that. Absolutely. Not thinking to at all. Okay, so Victor is telling us that we're gonna bring her into, is that what you wanna do, Victor? Bring her into the hospital for a
Yeah, just
second
come to the
checkup.
hospital, get a new on board. I love the
Love it.
peptides to make sure it's not
We have an oversight.
Yeah.
Okay, and then so,
And also, if it doesn't happen in the hospital, then it could be.
it could be surreptitious, yeah. I mean, people are very good at surreptitiously using stuff even in the hospital.
I brought the sulfonylurea levels on there.
Level on her too,
So,
yeah. So, some of this and a lot of this happens as part of the 72-hour fast. So I'll give you guys the labs that resulted at the end of it.
And how, like, was it a full 72 hours, or how long did she have to go before she had these symptoms?
Yeah, she had to go, about, like, 56 hours into it, yeah.
Was he so angry?
Okay, so at the end of the fast, her glucose was 48, and she had symptoms. Her insulin level was 6, which is high. Her C-peptide was was 1, which is high. Pro-insulin was 12, which is high. Her beta hydroxybutyrate was 1, which is low. And then, so traditionally at the end of the fast, you give the patient glucagon, because they're like super low glucose, right? And you let them eat then. And after giving the glucagon, her glucose rose by 36. Okay. You guys look at these for a second and see if anyone would like to interpret them. Okay, let's talk through it. What do you guys think that the insulin, C-peptide, and pro-insulin levels, when looked at together, are telling you anything?
Yeah, so she's secreting insulin.
Yeah, so this is our own endogenous insulin, because when we secrete insulin, it's in the pro-insulin form, then gets chopped up, and you get some of these end products. And so when all three are high, that means that's your body producing insulin. When the patient's taking insulin exogenously, only the insulin will be high, the C-peptide and the pro-insulin will be low, compared to the insulin level. Good, so we think it's her endogenous insulin. Do you think that her symptoms and everything is related to hypoglycemia?
Yeah.
Yeah, because this is a positive fast, right? She didn't go through the entire fast before she had her low glucose with the symptoms, and it got better when you gave her glucagon/food, and so she meets Whipple's triad. So we think her problem is due to hypoglycemia. And then the beta hydroxybutyrate, would you expect to be high or low? Well, it could be either. So now tell me, when you look at all of these labs together, what do you think it might be? Should the insulin be high when your glucose is this low? No. Okay. And so we're now worried that she has something that is producing insulin when it shouldn't be producing insulin. Okay.
What is the point of getting the pro-insulin?
I think it's like, it's to make sure, again, that this insulin is your body's insulin. I'm not exactly sure how the C-peptide doesn't tell you that, but it's part of the lab.
Right.
Yeah. Thomas and I think she's still taking sulfonylurea.
Oh, I forgot to mention that. Sulfonylurea are part of this panel that you get. And it's
Jaded
green.
senior.
I got kind of high. It was negative. She's not taking it. All right.
One other like interesting lab that would be considered would be like a lactate. I have heard like a horror story of someone having an insulinoma that was so bad that they essentially got a thiamine depletion because of that, and they had this persistent like lactate of like 10 all the time, and no one knew why.
It's like a B-type lactic acid.
Yeah.
Interesting, yeah. And so, you know, here in her case, like there are some variations of this conglomerate of hypoglycemic diseases where the beta hydroxybutyrate, if not low, like sends you in a different direction, but in an insulinoma or a hyperinsulinemic hypoglycemia patient, you should expect the beta hydroxybutyrate to be low because your body's appropriately utilizing all that glucose. All right. So what do you guys think now? What do you want to do now?
Some imaging of the belly.
Has anybody seen this before? How many of you have done a 72-hour fast in the hospital for a patient? Amelia? Andrew? Okay, I've done like 4. And so this isn't like super uncommon to come across at our hospitals since we're a quaternary referral center. So we want imaging. Okay, so what kind of imaging you want, Victor?
Start off with a CT.
CT of the belly. Yeah, I think that's a completely appropriate test to start off with. And any areas specifically in the CT you're going to be focusing your eyes on?
Pancreas.
Pancreas, yeah. Looking for any masses and tumors in the pancreas, which in her case is like inevitably supposed to be an insulinoma. And the CT actually was normal.
It was on one of the
They were very small slices. Or big, whichever is supposed to do.
Run it again.
Run it again. All right, so what I'm going to do now is, unless people, maybe not Amelia, but the rest of you, if you know where we go next in this case, feel free to speak up, but otherwise we'll sort of launch into a little bit of teaching about what's going on with this patient.
I will say there are extra pancreatic insulinomas.
Yeah, that's true.
Person's had fun.
I don't know.
Pan CT, all right, we're going for a pan CT now, because we think there might be a neuroendocrine tumor. So, okay, pan CT was also normal.
Like, rare.
So I'm obviously presenting a rarer finding than an insulinoma, right? And I don't expect all of you guys to know this, but it was an exercise in sort of talking about a patient that has this hypoglycemia and how we work them up. And so basically at this point, I think all of this, not all of it, you should involve endocrine right when you're going to do the 72-hour fast, because they need to help you work with our nursing colleagues and like walk people through how to do this exam, which can be pretty scary to do. And we'll talk through some of it. And so really at this point, when the imaging comes out normal, so really like endocrinology is going to drive the ship and tell you what to do next. So let's look at what we should do.
Do you get a PET scan?
Yeah, yes, that's going to be part of the workup. Yeah. So we're talking today about hypoglycemia in a non-diabetic patient. And so in diabetic patients, like it's a whole other scenario you're looking at. So these patients can be of any age and present with hypoglycemia. And I think you guys did a good job in our differential sort of toward the end of making sure that we talked about, hey, is this because of another illness that this patient has and why they're hypoglycemic? So make sure we're ruling out critical illnesses sort of at the top. And then we talked about surreptitious or drug use. We talked a little bit about other hormonal changes. And then mostly, though, for people who appear well, as this patient did, you're in this sort of endocrine pathway of endogenous hyperinsulinism, and it has a few different differentials in here. Patients that have had gastric bypass surgery present like this more often, and they have a variety of syndromes they can experience. Post-gastric bypass hypoglycemia is one, and then dumping syndrome is another, and I'd encourage you guys to look into those, because those patients I've seen way more frequently than patients like her. You can also have autoimmune changes, and you basically just send an antibody to insulin along with your other labs that we talked about, and that was negative in this patient, but if it's positive, it's more likely to be an autoimmune hypoglycemia. And then, of course, we talked about this last section here, which is why you send that sulfonylurea screen as well with your fasting labs. All right, so how are you going to approach this? So really, in any patient that sort of presents with our tremulousness, sweating, lightheadedness syndrome, you honed into, I think this is sympathetic surge type picture. You guys appropriately asked all the right questions. You want to make sure you're really talking about the timing of their symptoms, what their response is to food, asking, multiple times about drug, alcohol use, and their medication use, which I think you all did, and then family history, specifically to think about, like, are there any adrenal or MEN type syndromes that run in the family that I have to now think about in this patient. And so once you do all that, when you have high suspicion or proof of Whipple triad, as Thomas very astutely mentioned early on, you want to give the patient a glucometer because you need to prove that they're having Whipple triad. Really, you have to meet that criteria to be called a hypoglycemia patient. And so if the Whipple triad is not fulfilled, you're kind of off this track that we're going to talk about today. And either the patient has idiopathic postprandial syndrome, which used to be called reactive hypoglycemia, but in fact is not hypoglycemia. So what'll happen is the patient will be feeling symptoms. They check their blood glucose and it's not less than 55. And so they just have this sort of other syndrome that is not well explained otherwise. And then other causes, which we ruled out, thyroidism, hyperthyroidism, pheochromocytoma, anxiety, and all of those sort of fall into the other. So if the patient doesn't meet Whipple triad, look for something else. If they do, as this patient did with all her low glucoses when she measured them at home, then the next step is to admit the patient to get some more labs and to do a supervised 72-hour fast, because now we're worried that this patient has hyperinsulinemic hypoglycemia. So how does that fast work? It's challenging, and you have to have really excellent communication with your nursing staff because, they're not used to letting people's sugars drop below, like, 70, 60s. It becomes pretty uncomfortable. And in this case, you, really want the patient's sugar to be very low. So at the beginning of the fast, you're sort of going to be collecting labs every 6 hours. You're going to be doing intermittent point-of-care checks. And as the sugar starts to go down, after a certain cutoff, so once the sugar is less than 60, you start doing labs more frequently, so 1 to 2 hours. So you need to make sure the patient has excellent access, either a central line or a PICC line, so that nurses can draw labs frequently. And then you want to make sure the patient doesn't have, poor circulation, Raynaud's. They don't have a blood pressure cuff on that arm because your point-of-care checks and the lab checks can be abnormal, so you want to do it with free-flowing blood, and so something like a PICC line or central line can be useful. And then what the lab will do is only run these extra tests if the patient's blood glucose level is less than 55 on the BMP. So once you see the point of care go low, you got to do a BMP, make sure that glucose is also low, and then if it's low, then they're going to run these other tests for you. And then the fast ends when the patient has symptoms. So even if the sugar is 45 and they're not having symptoms, you keep going with the fast and you keep letting them drop until they have symptoms. And then when they have symptoms, you got to remind your nurses to not treat right away. You got to draw those labs first, and then you can treat with glucagon and let the patient eat. All the times I've done this, really essentially just had to restart because I think our ancillary care staff gets nervous. And they will treat the patient with glucagon or ample D50 or something, and then you're back where you started. So you have to start the fast all over again. So I would encourage, if you're going to be doing this at any time, go with your endocrine fellow and talk with the charge nurse and really get really experienced nurses to take care of this patient and tell them to not be scared of the glucose being low because that's what we want to happen. All right, so you guys don't have to memorize this table, but essentially what we're looking for are all these labs and their cutoff values, and most normally ending up in this middle box where most of our differentials lie. So once you've ruled out oral hypoglycemic agents like sulfonylurea, which should turn up positive on the screen, what you're left with are some of these other more rare diagnoses, and so let's talk about those. So the one that you picked up on is insulinoma, and the one we hear most commonly about because it is the most common, and it occurs in about 90 to 95% of patients that have hyperinsulinemic hypoglycemia. So to diagnose insulinoma, really, you're going to do the things you guys talked about already. It can be diagnosed with an EUS and sometimes you'll see an hypocoagulation in the pancreas. It can also be diagnosed with a CT scan or an MRI, and you're just going to be looking for masses in pancreas usually. But like Jake said, you can have extrapancreatic insulinomas, so if you're still very suspicious, you may do a more broad scan. Then the next set of diagnoses, if it's not insulinoma, are something called non-insulinoma, pancreatogenous hypoglycemic syndrome, NIPHS. And NIPHS presents differently in different patient populations. So the first patient population that it presents in are the bypass patients I mentioned. They're not the scope of our talk today. But when you look for insulinoma and you don't find one, then you're concerned that the patient has NIPHS. And what you're going to do is something called a selective arterial calcium stim test. And what they do is, I'm guessing IR is the one who does this. They basically go in through your arterial supply and they inject calcium into these different arteries. And then once they inject, say, in the splenic artery, they'll wait and they'll test insulin levels in the hepatic vein. And they'll then sequentially test each of these arteries. If they find insulin levels in the hepatic vein diffusely, then the patient has something called mastidioblastosis, which is a diagnosis that this patient had. And what happens in these patients is that these islet beta cells just hypertrophy and these islets grow in the pancreas, and they sort of mess with your glucagon insulin secretion from the pancreas. And so it's just inappropriate insulin secretion, inappropriate glucagon response to low blood sugars. And the treatment for a lot of these patients, so there are some standard treatments like diazoxide, you can do octreotide analogs to help treat this. But ultimately, if these oral agents aren't working, then sometimes you have to do debulking surgery and sort of just remove part of the pancreas. It can be guided by your testing here, like if it was mostly one of the arteries, then you can cut out that part of the pancreas to see if the patient's symptoms get better. And so sometimes you have to do these debulking surgeries. And so, these are sort of on one side of the spectrum. And then the last thing to talk about are these neuroendocrine tumors. And so most of these neuroendocrine tumors secrete insulin growth factor 2, which is what causes these symptoms. And so it's not directly insulin, it's this IGF-2. And in order to diagnose these, if you haven't picked something up on your other imaging, there's tons of different radio tracers that you can use. Normal FDG PET, you can do a dopamine PET, there is an octreotide scintigraphy, and then there's the newest is this dotatate scan, which can pick up with pretty good accuracy different neuroendocrine tumors. And so this is sort of the spectrum of illnesses that will cause you to have hypoglycemia if it isn't from surreptitious use or autoimmune insulin disease.
Yeah. 2 questions. So I feel like in the physical I've done, the fast 4 that were positive, get the CT, almost like if the CT doesn't show anything, I feel like regardless, they get an ultrasound of the pancreas, and until you have like the negative ultrasound, they don't move into the next stage of the workup. Because they're like, it's the pancreas. No, but it's still the pancreas. And then I was wondering, I don't know if there was like, if there's reasons that they would forego the ultrasound, or if that's what you saw as well.
I did not read enough to get to that part.
And then this is just
I'm not sure
my
the answer to
anecdotal
that.
experience of like, the 3 or 4 people I've done. And then for the NIPHS, because that's easiest to say, it just always scares me to take out body parts, especially pancreas. Does that increase their risk of like diabetes in the future or pancreatitis?
I think that's always a risk, and it's something that you have to tell the patients that you may end up using exogenous insulin now if we take out too much or take out the wrong part, or ultimately down the line, that's what ends up happening to you. So in this patient that we talked about doing debulking surgery, those are the risk factors that we talked with her about.
This was a real patient here?
This is a real patient that I took care of. Yeah. We sort of ended it with she was gonna think about, so we started some oral therapies. Acarbose is something these patients can have. You really want to try and eat these mixed meals, which are not like high in carbohydrate content and high in fat and protein content. So you can do some lifestyle changes and like some, oral medications to see if you can control your symptoms, but, ultimately, if that doesn't get you better with nocidioblastosis, you do have to do debulking, and so she was gonna like think about what she wanted to do.
Did you get a biopsy too, like a pancreatic biopsy?
I don't think she did while she was inpatient.
What do you think?
No, just, I thought it was a
Like just from
diagnosis.
histology. Yeah, it is a
Exactly,
diagnosis.
so.
Is this a like normal progression, like 6 months of sort of symptoms that worsen over time? Or is there like a natural history?
I think insulinomas can be variable, correct me if I'm wrong. I think it just sort of depends on until when you have enough insulin that your body can't keep up with the reverse mechanism that you get hypoglycemic. Nocidioblastosis is an acquired diagnosis, so that one does tend to have more of like a shorter course once you get it into the progression.
Are there any risk factors for nocidioblastosis?
I think there are, and I think has something to do with like, they've researched it more in the pediatric population, where it's seen more frequently than it is in the adult population, but I don't remember.
So is NIPHS the same as Nocidio?
NIPHS in non-bypass patients is inevitably from Nocidio, but in gastric bypass patients, it's to do with like what your pancreas saw before when you had all that extra weight, and then when you don't have that, how it reacts to what you eat is completely like thrown off. So actually the pancreas will expect to release more insulin than you need, and it will release all this extra insulin compared to what glucose you intake. And so these patients have a little bit different pathophysiology, and it's not really like the islet cell hypertrophy. So both of them, they fall into this NIPHS nocidio, and then patients who have had bypass.
How do you treat bypass? Do you do the same thing or no?
So bypass patients, it is all about oral medications and the mixed meals, and so really like you have to change your diet pretty dramatically to try and like eat enough protein, enough fat, enough bulky stuff to not have that transit too fast and not do a big glucose load to which the pancreas reacts inappropriately. Okay, I think that's all I had. Any other questions about this?
Good case.
Thanks. Thank you all for your participation. Great work.
Presentation.